Bismillah, alhamdulillah, salatu wassalamu ala rasulullah. Okay, well, thank you everyone for attending today. I hope the lecture will be useful and informative. And I'd like to pass my thanks to the organizing committee and my colleagues from earlier today, Dr. Tkhais, Dr. Rashid, and Dr. Ali. And from yesterday, Dr. Talal, Dr. Bawazir, for their and Dr. Alawi. It was very nice lectures. طيب, intestinal failure, it's actually not an uncommon disease. It's a condition that was considered fatal, but now, thanks to God, it's survivable and potentially curable. But it's a very delicate disease that needs lots of attention and lots of teamwork. We'll start with the definition. It's a state of insufficient intestinal capacity to fulfill nutritional demand of the patient. The kids has much more nutritional demand compared to adults, so the intestinal failure is more critical in the children compared to adult patients. This will result in dependency on parenteral nutrition and all its complications. Another definition is probably a little bit broader. It's a reduction of the functional intestinal mass below the minimum level necessary for digestion and absorption to satisfy the nutritional, fluid, and electrolyte requirements. In general, small bowel length less than 40 centimeters at birth is considered short bowel, and the patient very likely will be intestinal failure status. Another definition is parenteral nutritional support for more than 40 days after bowel resection is by definition intestinal failure. So intestinal failure is a big umbrella that has lots of pathological conditions. Short intestinal length is probably one of the most common, and it's the one that's really related to the surgical practice. Usually as a result of massive bowel resection from necrotizing enterocolitis or volvulus or others, or can be due to congenital conditions such as congenital atresia or gastroschisis. Poor motility is another entity where the patient has total or subtotal intestinal dysmotility or intestinal pseudo-obstruction. Congenital enterocyte disorder is another group of patients. Here in Saudi Arabia, we have few cases of tufting enteropathy. It's actually endemic here in Saudi Arabia. And I'm sure every one of us have seen one or two patients. Microvillus inclusion disease is another condition, and there's others. So for the sake of our presentation, and all the audience or most of the audience are pediatric surgery fellows or resident or in surgery practice. We'll focus more on short bowel syndrome, and we'll talk about the disease in general. And this is the information will be useful for other conditions of intestinal failure. So we'll talk about the definition, the medical treatment, complications of the medical treatment, and the surgical treatment options. So short bowel syndrome is a multi-system condition caused by suboptimal absorption of nutrient due to inadequate small bowel length. The residual intestinal length of less than 25 centimeters of expected for the gestational age is by definition a short bowel. Or if the patient requires PN for more than 42 to 90 days in some other definitions after bowel resection. Okay. As an underlying cause, there is prenatal causes such as atresia, as we mentioned, Apple-Beal syndrome, as Dr. Tkhais mentioned earlier, mid-gut volvulus and malrotation due to malrotation, segmental volvulus due to omphalocele or tight gastroschisis, abdominal wall defects, and extensive Hirschsprung disease. Neonatal cases, mid-gut volvulus and necrotizing enterocolitis probably the most common, and postnatally mid-gut volvulus, complicated conditions such as intussusception, internal hernias, arterial thrombosis, or massive venous thrombosis. Trauma and mesenteric injury, extensive angiomas is other rare causes. The small bowel length elongate during gestational age. In extreme prematures, between the age of 19 and 28 weeks, the average length of small intestine is about 142 centimeters. These numbers are based on post-mortem studies on patients who were born prematurely and patients who were born later on. and they measured the intestinal length at those patients, and they came with these numbers. So preterm, between 19 and 28 weeks, the average length is 142 centimeters, compared to late preterm, after the age of 35, the bowel length, the small intestine length, almost double, 300 centimeters. This information is very useful because if you operate on someone with necrotizing enterocolitis at age of 25 or 26 weeks, whatever residual small bowel, they're probably gonna double by the time they are term. So if they are short bowel at the beginning, they might not be at term of closure. At term. Short bowel syndrome is not uncommon. There is about 24 cases per 100,000 live birth. Among patients who are born less than 1.5 kilograms, there is about 7 per 1,000 cases. The numbers are increasing because of improving the NICU care, especially for extreme premature patients, and they are accepting to resuscitate less and less or smaller gestational age, 24 weekers, sometimes even 23 weekers, less than 500 grams. All these are at high risk of necrotizing enterocolitis and bowel resection. The overall survival for short bowel syndrome is anywhere between 50 to 90%. Those depends on many factors. Residual small bowel length is a significant factor. The type of the small bowel the small bowel and presence of the colon is another factor. Depends on the underlying cause and depend on the center. Centers who has more experience with short bowel cases, they have better survival. Centers who offer transplant, small bowel transplant, interestingly enough, they have less survival with the short bowel syndrome. The overall, the mortality, usually the underlying cause of mortality is sepsis and liver failure. So the management of short bowel syndrome depends on probably 4 pillars: the nutritional support, intestinal rehabilitation and adaptation, prevention of complications, and at the last, surgical treatment. So I'll talk about each pillar separately. Nutritional support. Parenteral nutrition is key. Start PN early. Meticulously calculate the fluids, electrolytes, and micronutrients and energy requirement. You have to have a team. It has to be a comprehensive and very interactive and cooperative team. You need pediatric GI, you need dietitian, of course, surgeon, clinical pharmacist, and registered nurse. You have to have a team to treat those patients. You cannot do it alone. You need good central line. Ideally, big lines or Broviac catheters or tunneled external catheters are the ones that's preferred. Everyone knows a BIC line. BIC line is peripherally inserted central catheters inserted in one of the veins in the arm, usually the antecubital vein, and it goes all the way to the atriocaval junction. Broviac or Hickman catheters are the other option, where they have tunneled catheters underneath the skin and inserted to one of the neck veins. Some centers, they use implanted ports, such as Portacat or IVAD. It's not recommended for TBN use, but in extreme cases, you can use them, but it's not recommended. So the insertion of the central lines has to be in sterile environment under general anesthesia, pediatrics, of course. It has to be aseptic technique, X-ray to confirm the position. You want the tip of the line to sit in the atriocaval junction right here. You don't want it anywhere proximal because the long-term TBN use will irritate the vein, cause thrombosis and stenosis, and you lose the vein very quickly. Bear in mind the child is growing, so the length has to be in appropriate side. Calculation. The protein requirement should be anywhere between 2 to 3 grams per kilogram per day. Fat emulsion or intralipids, you try to aim for 1 to 2 grams. Or 1.5 to 2.5 grams, should not exceed 2.5 grams per kg per day. For any reason, if you are giving less than 1 gram per kg per day, you need to add essential fatty acids. Trace elements and daily blood work until PN stabilized. You need to monitor the patient carefully. The PN stabilization and optimization period takes anywhere between 4 to 8 weeks. What do we mean by this period? That the patient has almost daily adjustment of the PN support, electrolytes, protein, and so on and so forth, until they reach a stable amount where you very much do very minimal changes in their daily PN volume and concentration. The target urine output should be anywhere between 1 to 2 ml per kg per day. You want stable electrolytes and stable weight gain. Once the PN has been stabilized, then you start the small bowel rehabilitation or intestinal adaptation program, which takes between 6 months to 2 years. It's a slow process. Actually, start right away after the bowel resection, but it's probably more visible once the enteral feeding has started. It's a slow process of intestinal rehabilitation. The bowel will dilate slowly. The transit time of the intestine will slow down. The alveoli will become longer, and the crypts will be deeper. The process of adaptation or rehabilitation is promoted by many factors. The presence of nutrients in the small bowel lumen, mainly long-chain fatty acids and essential amino acids, pancreatic and biliary enzymes, endogenous hormones, and patient overall status, nutritional status. Patient who's well supported by PN, they have better chance of being rehabilitated quickly. The enteral nutrition, which we mean by feeding through the normal routes, which is the intestine, we should commence the enteral feeding as early as possible. It helps promoting intestinal rehabilitation and maintain the mucosal blood barrier. Consider continuous feeding rather than bolus feeding because it will slow the transit time and have more exposure between the nutrients and the small bowel lining, which help the small bowel rehabilitation and adaptation. G-tube is ideal on those patients because you know that they will need continuous feeding for a very long period of time, and consider doing the G-tube early. You can allow bolus feeding to prevent feeding aversion, oral feeding, typically once to twice a day. You can introduce solids as a complementary food at the age of 6 months. The composition of the feeding, human breast milk or express breast milk is the best option. If you don't have it, then amino acid-based formula, such as Nucate, is alternative. We don't recommend partially hydrolyzed formula like Peptamen Junior or other formulas because it has higher allergic reactions and decreased intestinal barrier function. Vitamin and trace elements. The vitamins that commonly deficient in those patients are fat-soluble vitamins such as vitamin D and others, zinc, iron, and vitamin B12. So consider adding those to the PN. We have water-soluble preparation of vitamins, so they can be given orally. Vitamin B12, there is a sublingual or intranasal spray available as well. Monitoring the process of enteral feeding and intestinal adaptation is another thing that the team has to follow. There is many things that you can look for. Anthropometric weight, height, Z-score, triceps, and abdominal fat is the things that you look for. Make sure the patient is gaining weight and height and has enough fat. Plasma level of electrolytes, albumin, protein, vitamins, and vitamin B12. Every now and then you need to do contrast imaging to look at the small bowel diameter and the small bowel transit time. Methyl glucose can be used to see how much glucose being absorbed from the intestine, and blood work that can be useful to measure the amount of mucosa that's being developed is plasma citrulline level, which is byproducts that released by the intestinal mucosa. The higher the citrulline level, the more intestinal mucosa is there. So you can compare it between time to time, like do it every 3 months or so. Plasma GLP-2 level, which is glucagon-like peptide 2 level, help you in knowing how much endogenous GLP-2 available. Medication that helps with alleviating the symptoms of short bowel, such as diarrhea. Anti-secretory agent will help reducing the diarrhea. Antacids is a must. Patients who are short bowel, they have high endogenous gastrin level, so they are prone to have peptic ulcer disease and bleeding. So they need to be on proton pump inhibitor. Loperamide and octreotide can be used, usually over a short period of time. Don't give it for a very long time. Bile acid sequestrants such as cholestyramine can be used as well to alleviate the symptoms or the diarrhea associated with the bile acids. If the patient has intractable diarrhea, you can use in conjunction with loperamide diphenhexylate atropine, which is a combined drug. Atropine, which is anticholinergic medication, and diphenhexylate is opioid receptor agonist, which is going to slow down the intestine and reduce the secretion from the intestine, which alleviate the symptoms. Both of these should be used over a short period of time and then stop and reassess. If the diarrhea is persistent, consider using clonidine. Clonidine is alpha-2 agonist, which is used as antihypertensive medication. It has one of their side effects is actually slowing the intestinal mucosal secretion, so can be used on low doses. The starting dose typically is 0.1 milligram per kg per day and can be increased slowly every 3 to 5 days to reach a dose of 0.5 milligram per kg per day. There is clonidine batches available as well, which can be helpful. Will secrete the clonidine over a longer period of time, so can be useful in alleviating the symptoms without showing significant side effects. Be aware you have to watch for the blood pressure, because it can drop the blood pressure, and you have to check the renal function. Hormonal treatment, on the other hand, glucagon-like peptide is an enteroendocrine hormone secreted normally by the terminal ileum and colon mucosa. The function of this hormone is to slow down the transit time of the intestine and stimulate small bowel epithelial proliferation, resulting in longer villi, small bowel epithelial villi, and crypts, as you can see in the diagram here. The L cells are present in the terminal ileum and the colon. So patient after bowel resection, if they have intact terminal ileum and colon, they have enough endogenous glucagon-like peptide compared to those who doesn't have terminal ileum and colon. That's why patient who has TI, they are prone, or they have higher chance of being weaned of TBN. Anyway, so they are secreted by the mucosa here. They found that patients who undergo bowel resection, there is a slow process of intestinal rehabilitation. Will start right away after the section. It takes some time, 1 to 6 months to a year. But if you give them supplemental glucagon-like peptide hormone, the natural process of bowel adaptation will be accelerated over a shorter period of time. Not only this, if you give them higher doses of glucagon-like peptide, like 2 or 3 times the doses, you can induce hyper-accelerated intestinal adaptation. So glucagon-like peptide was found to be a key thing in treatment and management of short bowel syndrome. 12 weeks treatment of glucagon-like peptide analog, which is long-acting, is tidglutide, 0.0125 to 0.025 milligram per kg per day, versus placebo showed there is a trend toward a reduction of PN over a 12 weeks period. Another study done in Denmark comparing tidglutide to placebo in patients with short bowel syndrome and intestinal failure. All the patients, they have around 90 patients. They underwent a process of optimization of their TBN over a period of 8 weeks. After their TBN being stable, they were randomized into tidglutide or glucagon-like peptide analog and placebo. The dose they use is 0.5 milligram per kg per day, and they give it over 24 weeks period. And they followed those patients every 48 hours by checking their urine output, their serum protein, and their overall nutritional status. If their urine output drops, then they don't have enough TBN. They will increase their TBN volume, usually volume and concentration. If their urine output stable, they continue the same TBN. If their urine output increased by 10%, then they will reduce the TBN, which means indirectly their intestine is absorbing more. They are becoming more efficient in the absorption of enteral nutrition. They will reduce 10% of the TBN and increase 10% in their enteral nutrition supplement. And over the 24 weeks period, they found patients on the treatment group, the tidglutide group, they were twice as efficient in their bowel rehabilitation. By the end of 24 weeks, they were able to reduce average of 4.5 liters per week of their TBN. Compared to the placebo group, they reduced about 2.3 liters per week. Now, somebody will ask, even the placebo group, they improved. Yes, they will improve because they have natural GLP-2 hormone, but the amount is not enough to induce the hyper-accelerated adaptation compared to that we saw in the treatment group. So what are the complications we see from medical treatment, TBN and enteral feeding in patients with short bowel syndrome? Those are the 3 most common complications: bacterial overgrowth, intestinal failure, liver disease, and line sepsis. And we're talking, all these are potentially life-threatening complications. We take them one by one. Bacterial overgrowth is common among short bowel syndrome patients or intestinal failure patients. It's due to abnormal intestinal motility. The intestinal motility is slow, so there is more time. The transit time is longer, and the natural flora will have more time to grow. Resection of the ileocecal valve will have influx of or reflux of colonic flora into the small intestine. The use of antacid will reduce the amount of acidity in the stomach, and the small intestine will give better media for the small bowel flora to grow. They will reduce the absorptive capacity of the intestine because they will damage the intestinal villi. Their overgrowth will cause irritation to the intestinal villi and ongoing damage. They carry higher risk of bacterial translocation and catheter-related sepsis. And the last thing is acidosis. There is a special entity called D-lactic acidosis associated with bacterial overgrowth. Diagnosis of bacterial overgrowth, it's mainly clinical. The patient, only a few patients may show low-grade sign of low-grade sepsis. Patients being unwell, having some diarrhea, maybe fever, maybe leukocytosis. Intractable diarrhea is another one, and feeding tolerance. Like the patient used to tolerate a certain amount of feed, suddenly he's not tolerating that amount anymore. You try to reduce it, still he's not doing well. This is another indication that the small intestine, there is decline of the intestine function. Other invasive ways of making the diagnosis is sampling the small bowel mucosa by endoscopy, or taking a sample from the duodenal fluid by inserting nasoduodenal or nasojejunal. But like I said, those sampling methods are rarely used and rarely done. The diagnosis is clinical, and if you suspect it, then you have to treat it. How to treat it? Usually by oral antibiotics. We call it cycling antibiotic regime. You can choose one antibiotic or a combination of 2 or 3 antibiotics. If you choose one antibiotic, then give it once a month over one week period, and give the patient break for 3 weeks. But more commonly, in clinically significant patients, you should treat them with 2 or 3 antibiotic choices. Amoxicillin, gentamicin, oral gentamicin, and metronidazole. All these are should be given orally. Given each one over a 1 week period with 1 week break in between. So 1 week of amoxicillin, 1 week of no antibiotic, then 1 week of gentamicin, then 1 week of no antibiotic, then 1 week of metronidazole, then 1 week of no antibiotic, and repeat the cycle again. Probiotics has been tried, but it's not recommended because it's associated with the high risk of bacterial translocation and sepsis. There is few cases of lactobacillus sepsis in infant with short bowel syndrome being treated with probiotics. So it's discouraged, and it's not recommended. D-lactic acidosis is a special entity seen only or mainly in intestinal failure and short bowel syndrome. It presents with neurological symptoms such as delirium, slurred speech, encephalopathy, and coma in severe cases. It's acidosis, so the patient will have high anion gap. But if you check their serum lactic acid, it's normal, because normally the labs will check the L-lactic acid, not the D-lactic acid. So what D-lactic acidosis? Patient with the short bowel syndrome, they have short bowel, so they are not absorbing nutrients as well. So they have high amount of carbohydrate reaching the colon and the terminal ileum. With the background of short bowel syndrome and bacterial overgrowth, they have lots of anaerobes and bacteria in their colon. The fermentation of the carbohydrates results in high level of D-lactate or D-lactic acids. Normally, the liver will process those to pyruvate and then glucose. But in patients with short bowel syndrome, they have very high amount of D-lactic acid being formed. It's overwhelming to the liver, cannot deal with it. Besides that, their liver is probably not at their best shape. They have ongoing liver disease related to the TBN. So this will result in high D-lactate in their serum, which goes across the brain blood barrier and cause encephalopathy. How to diagnose it? Check the serum D-lactic acid level. If it is more than 3 millimole, this is diagnostic. How to treat them? Correct the acidosis, restrict carbs, and cycling antibiotic or bacterial overgrowth eradication with metronidazole, gentamicin, neomycin, vancomycin, or whatever. And then maintain the bacterial overgrowth treatment protocol. The second common complication is cholestasis and liver injury. Typically, patients who are receiving parenteral nutrition more than 2 weeks, they are prone to have liver injury. Enterolipids, which mainly a product of soybean or sunflower sunflower. They're rich in omega-6 fatty acids, which produce pro-inflammatory cytokines that cause direct injury to the hepatocyte, causing the liver injury. Being-induced cholestasis, typically patients will have increased direct bilirubin 2 to 3 times the normal. They have hepatocyte injury, necrosis, and fibrosis, so the liver enzymes will be elevated as well. Liver transaminases and other enzymes will be elevated. Measures that the clinician can do to alleviate the symptoms or reverse the liver injury compose mainly of reducing the fat emulsion to 1 to 0.5 grams per kg per day. Try to cycle the PN over 16 to 20 hours instead of 24 hours, giving the liver like 4 hours break between the PN cycles. Increase the enteral feeding. If the patient is not receiving enteral feeding, then commencing enteral feeding will alleviate the symptoms. And switching to omega-3 fatty acids, based fatty acid, fish oil. In the market, we have SMOF-lipid, and in Europe, they have omega-van. It helps reversing the cholestasis and alleviating the liver injury. There's many studies that check the safety and the efficacy of fish oil treatment in patients with PN-associated liver disease. This is just one of them. They compared 3 types of intralipids, 3 types of lipid emulsion, intralipids, liposin, and omega-van. So omega-van is mainly fish oil compared to intralipids, which is mainly soybean, and liposin is combined soybean and safflower. The amount of essential fatty acids is very much similar, except in linoleic acid is not available in the omega-van. So it's something you have to keep in mind. Over a period of so they enrolled patients to receiving the intralipids and the fish oil, and they compared their liver function. Patient who has cholestasis and all the measures of reducing the PN, the intralipids, cycling the PN, and so on and so forth, showed that it will reduce the cholestasis over long period of time. They need about 42 months or 42 weeks to alleviate, to reduce the cholestasis and the direct bilirubin to have. Compared to patients who are receiving omega-van, the period was much faster. So omega-van is very useful in, or fish oil in general is very useful in patients with cholestasis. It's associated with liver disease, associated with PN support. Omega-3 fatty acids, there is two available in the market, omega-van, which is mainly fish oil, or SMOF-lipid, which is a combination of soybean, MCT oil, olive oil, and fish oil. I know this is available in Saudi Arabia, and we're actually using the SMOF-lipids. It's used as a secondary prevention of TB and cholestasis. Some centers, they use it as a primary prevention. They, knowing that the patient will require PN for a long period of time, they start them in SMOF-lipid right away. The third complication, and probably the one that we deal more directly with, is central venous access infection. Patient with PN support for long period of time due to intestinal failure, they are prone to have central line infection. About 10% of all lines develop central line associated infection, CLABSI. Most common organisms are gram-positive organisms. Less common is gram-negative. Fungal and anaerobes are much less. Source of infection could be the skin, or during insertion, or contaminated solution, or hematogenous spread from elsewhere. It can be early, less than 6 weeks, or late. Overall, the classification, either local infection at the site of the insertion by erythema, purulent discharge, skin necrosis, and so on and so forth, or bloodstream infection, which can be uncomplicated or complicated if the patient has severe sepsis or septic shock, hematogenous spread, osteomyelitis, thrombophlebitis, lung abscess, and so on and so forth. In this patient, this is a patient who developed lung abscess secondary from hematogenous spread of central line infection. This patient has thrombophlebitis at their neck veins. This patient developed osteomyelitis from central line infection. How to diagnose CLABSI? If the line in place, send simultaneous blood and blood culture, peripheral blood culture, and central line culture, and look at the colony forming unit. If you have 4:1 colony forming unit from the central line compared to the peripheral, this is diagnostic. The other criteria is the timing of positivity of the culture. If there is 2 hours difference, again, this is diagnostic. If you remove the line, then you send the tip for culture. Should we remove the line if it is infected or keep it? Can you answer? Should you remove the line if it's infected or keep it? See if you are awake.
Yeah, the answers will be in the chat. Some of them they said keep it. Some of them they said remove it. But most of them they said remove.
Remove. Okay. Well, it depends. If it is complicated central line infection, then it has to be removed. If it's uncomplicated, then it depends what kind of organism. If the organism is Candida or Staph aureus, the line has to be removed. If the organism is gram-negative bacilli or coagulase negative staph, then you try to preserve the line. Give them antibiotic plus systemic antibiotic plus antibiotic clock treatment. Repeat the culture after 2 to 4 days. Prefer blood culture, make sure it is negative. If it is negative, then continue the treatment for a total of 14 days. If the culture after 2 to 4 days is positive, then you have to remove the line. Means you cannot eradicate. Why we try to keep the line? Because those are very valuable line. If you remove it, then you are already utilized one site and it's very hard to go back and use it again. Now, how to prevent line infection? At time of insertion, so observe aseptic technique, or during access, again, the nurses has to be educated how to access the lines, or during lockout period between the TBN use, try to use some medication to reduce the infection. After eradicating implant or central line infections, high-risk patient who has history of infected CVC or risk of neutropenia, you should consider antimicrobial lock treatment. The antimicrobial can be antibiotic, such as vancomycin, amikacin, gentamicin. It depends what kind of organism, and check the culture and sensitivity. Then you start the lock treatment, or use antiseptic solutions, such as ethanol, 70% ethanol. This is a meta-analysis comparing antibiotic lock treatment versus no antibiotic lock treatment. They found that antibiotic lock treatment reduced the risk of infection by almost half. So consider antibiotic lock treatment as a primary prevention in high-risk patients, such as newborns or neutropenic patients, or secondary prevention in patients who previously developed central line infection. Bear in mind there is a risk of emerging drug resistance from antibiotic lock. That's why ethanol lock is probably more popular in patients with short bowel syndrome or intestinal failure. This is a study comparing ethanol lock versus nothing, published by Dr. Paul Wales from Sick Kids. Patients with tunnel central line catheters less than more than 5 kilos had history of CLABSI, one episode of CLABSI on home TBN, have 4 hours off cycle TBN, so the TBN over 20 hours, and they used 70% ethanol. Dwell time was 4 hours when the TBN is off, replacing the standard heparin lock. This is the patient characteristics, and they found that introducing the lock treatment reduced the risk of infection from 10 per 1,000 CV central line days to almost less than 1 per 1,000 days of central line catheter in place, which is a very significant drop. So was recommended, and it's the routine. It's almost universal. All the centers, they're using ethanol lock now. Another study, the lines they were using were Proviac and BIC lines, and they compared their control group with the patient with ethanol lock, and you can see the difference in risk of infection per 1,000 days of central line in place. So introduction of ethanol lock reduced infection significantly. Now, at the last, I will talk about the surgical treatment of short bowel syndrome or intestinal failure. There is 4 components. At the initial procedure, at time of resection or exploration, or introduction of feeding and closure of the stoma, bowel lengthening procedures, and intestinal transplantation. So if you see this bowel during exploration, should you resect it? Should we keep it? What we should do? What do you think? Can you answer? Hello?
Okay, they are, doctor, in the chat. Second look, they said, some of them, they said no resection. Most of them, they said wait and do second look.
Okay, yeah, that's reasonable. So the idea is to minimize the resection as much as you can. So if you see the bowel looks like is not perforated, it's probably questionable, then de-twist the bowel if this is whatever the underlying cause of the ischemia, deal with it, and then drop the bowel, close the abdomen temporarily, and bring them for second look after 24 to 48 hours. Consider gastrostomy for tube feeding, close the stoma and restore the bowel continuity later on, because this will facilitate adaptation and reduce liver injury. The patient will tolerate the feeding better if they have the ostomy closed. Bowel lengthening procedure: taper the small bowel diameter, lengthen the existing small bowel, which will help reducing the stasis, improve the absorption by increasing the contact to the mucosa, and minimize bacterial overgrowth. There is three options or three surgical treatment for small bowel lengthening. There is Bianchi procedure, or longitudinal intestinal lengthening and tailoring procedure, serial transverse enteroplasty or step procedure, and lastly spiral intestinal lengthening and tailoring procedure. Bianchi described his procedure in 1980. First case was done a year later in 1981. This was a 4-year-old who has 50 centimeter small intestine, and he was off TB in 8 weeks later. This is the Bianchi procedure. So it's a longitudinal split of the mucosa, of the bowel and their mesentery, then dividing it and anastomosing it in isoperistaltic fashion. So bring A to B to keep the peristaltic wave in the same direction. Another picture. Limitation of Bianchi procedure is technically difficult. There is risk of ischemia and leak, and there is risk of stenosis and stricture. Kim in 2003 described the step procedure, which, as you can see, it's fastening the small bowel in zigzag shape by cutting almost 3/4 of the bowel width in alternating side, keeping about 1.5 or to 2 centimeters distance in between, to keep the lumen diameter about 2 centimeters all the time, 1.5 to 2 centimeters. This is a picture of a patient with intestinal failure secondary to short bowel, underwent lengthening procedure. As you can see, the bowel was divided this shape to make it zigzag shape. It was 30 centimeters prior to the step procedure. I think it reached about 75 centimeters after step. Comparing Bianchi to step procedure, there are many studies was done in this regard. I just mentioned one of them. Risk of bleeding was higher in the step procedure group. Risk of obstruction is the same. Leak is about the same. Abscess formation was more common in the Bianchi group. Intestinal necrosis, perforation, and fistula formation was only present in Bianchi procedure. So major complication is very rare or negligible in step procedure compared to Bianchi procedure. Not only that, mortality was less in the step procedure, and time for weaning of TBN was less in the step procedure.
Dr. Akram?
Yes.
15 minutes to go. Just if you
Yeah,
just 5 minutes, then 10 minutes for the question, if you don't mind.
Yeah. So which one you should choose, Bianchi versus step? It's driven by feasibility, and I think technically step procedure has an advantage. Less major complication with step, necrosis, fistula formation, and no mesenteric dissection. In patients with asymmetrical bowel, such as and jejunum and proximal jejunum, step procedure is feasible compared to Bianchi. Small bowel dilatation is common, both steps, so you can repeat step procedure 2 to 3 times. Even after Bianchi procedure, you can repeat the step. Versus Bianchi, you can do it only once. Spiral intestinal lengthening is a new procedure. I don't think we need to mention it or talk about it. Intestinal transplantation is something that you really try to avoid as much as you can. It's probably the one that has the least success rate. Indication for intestinal transplant is recurrent life-threatening central line infection, loss of venous access, vascular venous access, which is probably the most common, or advanced liver disease and portal hypertension. There is 2 types of intestinal transplantation, either isolated intestinal transplantation or multivisceral intestinal transplantation. The multivisceral can be small bowel or intestine and liver, or can be more than intestine and liver. Technically, the multivisceral transplant is probably the easiest. Actually, I helped in one of those. There's only 2 vascular anastomosis. You bring the recipient, you bring the donor aorta together with all the vessels, the celiac axis and the SMA, and you anastomose it to the recipient aorta, and the IVC, the suprahepatic IVC, anastomose to the recipient aorta. Compared to isolated small intestinal transplantation is probably the most difficult. You need 2 anastomoses, the SMA to the recipient aorta, and SMV to the recipient portal vein. In between is probably the least common, where you do liver and small intestine only. I think this is the least common, and I don't need to talk about. Intestinal transplantation, there is about 2,000 cases done in US, mainly in children's. There is the risk of acute rejection is about 90%. That's why it's not very popular. Graft survival is about 90% in the first year, drops down to 30 to 50% at 5 years. So in summary, we talked about the definition of intestinal failure, causes, medical treatment, nutritional support, intestinal rehabilitation, prevention and treatment of complications, mainly line sepsis, bacterial overgrowth, and D-lactic acidosis, cholestasis, and omega-3 fatty acids, bowel lengthening procedure, the Bianchi procedure, and the STIP procedure, and intestinal transplantation. And that's the end of, we are ready for
Okay. Thank you very much, Dr. Akram, for the informative, enjoyable, and really complex topic in our pediatric surgery community. Just if you don't mind, I can share the screen if you don't mind, Doctor. Okay. So the first question is regarding the central line. Do you prefer ethanol or heparin blocks?
Well, at the beginning, heparin lock is a must. Actually, the patient needs to be in heparin infusion mixed with TBN, as you know. Once the patient develop central line infection, or they are high risk group, like they have neutropenia, or they are going home on TBN, like home TBN, then it's better to use ethanol lock. Yeah, 70% ethanol daily.
Okay, next question. Is there any blood test or stool test to know completion of adaptation, or that patient is out of intestinal failure?
Well, the adaptation, there is two things in adaptation. The bowel will, it's actually improving the absorption of the existing bowel, and then trying to lengthen the existing bowel and recommencing the adaptation process, i.e. You increase the absorption of the intestine, the residual intestine, by reducing the transit time, giving the feed over 24 hours, the enteral feeding over 24 hours, use hydrolyzed, use amino acid based formula, and then to check if the patient is absorbing or not, there is two things. Check the weight, the urine output, and the electrolytes. Make sure the electrolytes is normal. And then check the stool for reducing substances, which indicate that there is some of the content is not being digested and absorbed. Serum citrulline is a marker for the amount of intestinal mucosa. So increasing the serum citrulline is a direct indicator that the patient is adapting. Now, the adaptation process is an ongoing process. Your aim is to increase the enteral feeding, make sure the patient does not develop diarrhea or overfeeding, and reduce the TBN until the patient is off TBN and completely in enteral feeding. Now, stopping the TBN cannot be like right away. You can stop the TBN every other day, then give them PN support 3 days a week, then twice a week, then once a week, and then stop it completely. And observe their weight gain and their electrolyte and so on and so forth. So it's not only one thing, it's many factors.
Very good. Any rule of fibers? Is there any rule for fibers?
Like to thicken the stool?
Yes, according to them.
You can use pectin. The patient has intact colon, you can use pectin. It will thicken the content and slow down the transit time, slow down the diarrhea. Plus the other factors like lopramide, you can use clonidine, you can use octreotide over a short period of time, and so on and so forth. I don't use fibers actually. They don't have constipation. If fibers are not, they will not be absorbed. If they have intact colon, you can use pectin, and that's about it.
Okay. Is there any protocol for progression of feeds?
Sorry, what's that?
Any protocol for progression of feeds?
Yeah, well, you start slowly and increase it as the patient tolerates. Once the patient develops diarrhea, then you need to slow down the enteral feed. So your marker is diarrhea, increase the reducing substance in the stool. If the patient develops diarrhea or dehydration, then you need to slow down the feed and go back.
Okay. What they said, why G-tube is better than NGT for continuous feeding?
You cannot keep the NG-tube for a very long period of time. It has, like, if you know that the patient will require G-tube for more than, or enteral feeding for more than, I would say, 2 months, just consider G-tube, gastrostomy tube. It's more reliable. The patient will not pull it out. It will cause less complication to the nose and the sinuses, and like the kid will feel normally and their development and so on.
Okay. Another question about how to choose the appropriate diet from start. Eventually, the increase of one and decrease of the other will lead to one of the complications. So his main question about the appropriate diet from the start.
What enteral diet, you mean?
Enteral diet, yeah. He means the enteral diet.
Okay, well, as I said, like for newborns or little kids, it's better to use the breast milk. If it's not available, then use amino acid based formula, and then you give them a bolus feed, like oral bolus feed, just to keep them from having oral aversion. Older kids, you try to give them hydrolyzed formula, like completely hydrolyzed formula rather than partially hydrolyzed formula. And if you see that they are absorbing well, then you can give them solid diet, like solid food twice a day or so. But mainly depend on the continuous enteral feeding using hydrolyzed formula.
Okay.
I don't know. Yeah.
One of the question is the lengthening procedure applicable for colon?
No, applicable for small bowel. And the diameter of the small bowel for step procedure, you need at least 4 centimeter diameter. For Bianchi procedure, you need at least 5 centimeter diameter of small bowel.
Very good. Another question with Dr. Farouk: when we will go for step or Bianchi?
Yeah, after I think I answered it. If the patient has bowel diameter more than 4 centimeters, then you can consider lengthening procedure. But it's not only the lengthening procedure. You want to make sure that the process of adaptation of the small intestine reaching its limit. Like really, the patient, you did as much as you can in adapting the existing small bowel. After you feel that the patient cannot progress anymore in enteral feeding, then you do upper GI contrast study, check the diameter of the small bowel. If the diameter is more than 4 centimeters, at that time you can consider a lengthening procedure. But if the patient has the diameter of small bowel of 4.5, but he's completely off TBN, there is no need for lengthening procedure. He's fine. Like this is just a complementary procedure to his intestinal rehabilitation process.
Okay, what about the follow-up protocol after the lengthening procedure or after the intestinal transplant?
After lengthening procedure, then you restart the feeding and increase the feeding as the patient tolerates. And again, reduce the TBN and increase the enteral feeding as the patient is tolerating. Sometimes one step is not enough for kids who has really extremely short bowel. You may need to bring them back for another step procedure after. Usually you need at least 6 months to a year. Like I have one patient who required 2 step procedure to be weaned off TBN. Now, the TBN, the patient can go home with TBN. I know it's not very common, but if you have a home TBN program in your center, the patient can collect the TBN from the hospital and get the TBN at home and teach the mother how to use the ethanol lock. And we have few patients who actually went through that program.
Super. Wallahi, there is a lot of questions really for the complex topic, but I will stop now. Thank you very much, Dr. Akram, for your time and for your informative lecture and really complex topic. You summarized it in a good way. Thank you for that, Dr. Akram. So if you have any question for Dr. Akram Aljahdli, his Twitter here is mentioned, and you can follow him up in the Twitter, and you can mention us in our Twitter Pediatric Surgery Review. So just to end for tomorrow,